We'll move to a new topic that is protozoal infections. There are various infections. These are amoebiasis, malaria, giardiasis, leishmaniasis, toxoplasmosis, and trypanosomiasis. These are six prominent, you can say, infections which are because of the protozoas. Everywhere the causative organisms are different. We shall see one by one, and we shall see the treatment for each. So these all protozoal infection, whatsoever they are, we have got something that is that difficult to be treated than bacterial infections. Why? Because there are more metabolic processes which are closer to human host. So far we have seen in all antibacterial drugs that whatsoever process we are doing, we are trying to affect the metabolism of bacteria, and we have seen that it is significantly different than human beings. Therefore, what our efforts or all the drugs which we have used, they were having comparatively more specificity towards pathogenic organism than host, and therefore minimal adverse effects we could see. But here actually, since they have metabolic process which is similar, which is closer to human being, and therefore because the thing is, because of that it will cause more adverse effect. Many of the antiprotozoal drugs, they are causing toxic effect to the host. That is another problem. Cells with high metabolic processes in the host, they are susceptible, and all the cells which are example of these are bone marrow, that is stem cells, renal tubular cells, then intestinal and neuronal cells which are having this. Then antiprotozoal are not safe during pregnancy. So these are various conditions which are problem, and because of that we find difficulties still. Whatsoever drugs we can have. So whatsoever drug we are having, these are for all these six, that is chemotherapy for amoebiasis, malaria, giardiasis, leishmaniasis, toxoplasmosis, and trypanosomiasis. So these are various treatments which we can have, and accordingly the drugs will be used for this. We'll start with the amoebiasis. It is caused because of the infestation from or infection from the amoeba. That is organism is Entamoeba histolytica, and this is the structure of it. It is a trophozoite. When ingested, the erythrocyte of this to the cyst, in that case how it looks like. So it is a protozoal infection of the intestinal tract that occurs due to ingestion of foods or water which is contaminated with the Entamoeba histolytica. Cysts are there. This we shall see the life cycle of this. That is, it has got two forms. One is called as a cyst, which is that way which is infective in nature. It can survive outside the human body for a long period of time, and then once it enters, then it becomes converted into trophozoites. These trophozoites are not infective, but they are invasive in nature. They can reproduce, they can feed on the intestinal bacteria, or they can invade and ulcerate all walls of the large intestine, and they can migrate to liver or other tissues. Recently it has been found that in some cases, in some places, they are reaching to brain also and affecting brain, and those unusual type of infections are very difficult to treat whenever they are causing. They are transforming to cysts which are excreted in the feces. Again, this is a life cycle. So this trophozoite are transformed into cyst, and these cysts are excreted in feces. From that it causes contamination. From that contamination it comes back to the body, and like that this life cycle goes. So how the life cycle works: cyst ingestion, formation of trophozoite, penetration into intestinal wall, multiplication of trophozoites within colon wall, systemic invasions, cyst formation in rectum, and excretion in feces. So this is how this works. It comes to that, it reaches to colon, and from that it can go to liver. In liver, these trophozoites are formed. It can also in intestinal wall also, anywhere it can have. So if it is, these are called as intraluminal cyst. These are converted into trophozoites, and then it can reach to liver, that is hepatic trophozoites. When it reaches to liver, then it can become still complicated one, because you need to have drugs which can be penetrating liver and which can be active against it. In colon, even the drug which are not absorbed, those which are reaching in GIT, they can be useful in that case. So we can have this systemic and classification, that is luminal, that is which are acting in the lumen of intestine. We'll call it as a luminal and amoebiacids. Tissue or systemic, those which can penetrate into tissues, and those which can penetrate into tissue can also get absorbed and go into blood, that will be systemic amoebiacids. And mixed, which can be both luminal as well as systemic amoebicides. So both we can have accordingly. These are the drugs. Lumen and amoebicides, they are acting on the parasite which are present in the lumen of the bowel or in the GIT or in the intestine. They are used for the treatment of the asymptomatic amoebiasis. They includes dialexonide. Now asymptomatic means there are no symptom of amoebiasis, which normally whenever it is in intestine it causes diarrhea, and it is very typical diarrhea which is very filthy smell, sticky or mucoid kind of stool. Very typical stools are there, and this particular thing is there, that is the symptoms of diarrhea or amoebic diarrhea. The drugs which are there, example of these are dialexonide, furet, aldoquinol. These are the drugs. Antibiotic like paramomycin, tetracycline, erythromycin can also be active against it. Then tissue amoebicides, which can work on liver, particularly on intestinal wall, and these are used for the treatment of systemic form of the disease. Example, that is intestinal wall infection or liver abscesses. Example of these are emetin, dihydroemetin and chloroquine, which can be useful only for liver. It is not useful in intestine. Now mixed one are there. They are useful against both kind, that is luminal as well as systemic form of the disease. Luminal concentration is too low for a single drug treatment, but they are very effective, and whole class of these drugs are there. We call them as a nitroimidazoles. Example of the first drug of that is metronidazole, which is still being there. Metronidazole, tinidazole, secnidazole, ornidazole. There are many nidazoles are there. So all these nidazoles are there. They are working in this way. So this is the first or most prominent drug is metronidazole. It is, we have seen, it is a mixed amoebicide. Why we call mixed? Because it is for systemic as well as for luminal amoeba. Drug of choice for both intestinal and extra-intestinal. It acts on trophocyte, but it has no effect on cyst. So when cysts are converted into trophocytes and they grow, they develop, then only it is useful, otherwise it is not useful. The mechanism is nitro group of metronidazole is reduced by protozoan, that is leading to a cytotoxic reduced product, and that will bind to DNA and proteins. They will result into death of the parasite. So it is amoebocidal drug. It is not a static one. It can be given orally or intravenously. Even it is available in other forms also. Absorption is rapid and it is complete due to rapid absorption from GIT. Not reliable, effective against luminal parasite, because it is if it is luminal one, it should remain in the lumen, but if it is rapidly absorption, then it will not remain in the lumen. Wide distribution is there in all tissues and body, including CSF, saliva, milk, etc. Plasma protein binding is low, that is less than 20%. Plasma half-life is quite high, that is 8 hours. It is metabolized in liver by various oxidases, and then it is glucuronidation, that is phase 2 reaction. Excreted in urine as unchanged drug plus metabolites. Clearance is decreased in liver impairment. Tinidazole is having longer duration, simple dosing regimen, less toxicity than metronidazole, but it is equally active. So tinidazole nowadays it has therefore been preferred over metronidazole. What are the clinical uses? It is extraluminal amoebiasis. It is combined with luminal anti-amoebicides. So it is used in giardiasis. It is one more type of protozoal disease. It is used in trichomoniasis. It is a broad spectrum anaerobic bacteria. That is, it is very useful in Helicobacter pylori infection. It is against Pseudomonas colitis and Clostridium difficult type of microorganism. Many places you will find that it is instead of amoebicide, it is used as a bactericidal drug against anaerobic microorganism. This is one of the best anti-anaerobic microorganism. So in most of the treatment, at many treatment, particularly in urinary tract infection, this drug is one of the most famous or most prominent drug or antibacterial agents. Adverse effects: nausea, vomiting, dry mouth, metallic taste, diarrhea, oral thrush. That is moniliasis, or it is called because of that there is a yeast infection that can take place in the mouth. Then neurological effects: it causes insomnia, it causes dizziness, it causes peripheral neuropathy, paresthesia. Paresthesia means loss of senses in certain area, sort of anesthesia, but here the abnormal sensation will be there. Encephalopathy, convulsion, particularly with IV infusion they are more, otherwise they are rare. Dysuria, that is, it will cause dark urine and problem. It causes neutropenia. It also causes disulfiram like effect. If you remember last year pharmacology, we have studied alcohol, and the disulfiram is the agent which is used as antabuse. It is also called as antabuse like effect because this disulfiram or antabuse, it prevent the metabolism of acetaldehyde to formaldehyde, and acetaldehyde to acetic acid, and therefore causes accumulation of acetaldehyde after alcohol ingestion, and that causes severe problem in the alcoholic person. And this is one of the medication which is used to prevent person going for alcohol addiction, or it is used for alcohol de-addiction. So this is how it is used. I told you about that ethanol to acetaldehyde, and this. Drug interaction, it is having many enzyme inhibition activities, like there are various enzyme inhibitions are there, like cimetidine, ketoconazole. They will increase the duration of action of metronidazole. There are certain inducers of the metabolism or metabolic enzyme. Example of these are phenothione and phenobarbital will cause decrease in the plasma concentration. It inhibits CYP family of 2C9 and 3A4. It has got increase in the anticoagulant effect of the warfarin, and then therefore it has to be carefully given if already warfarin is going. It will potentiate lithium toxicity, and therefore that care has to be taken. Then pregnancy and nursing women, it should be care should be taken. During alcohol intake, already I told you that it can cause this effect, and it can be very severe during CNS effect, because it has got neuromuscular effects, and because of that during that it has to be used very cautiously, carefully. Severe hepatic disease, severe renal diseases, in both cases it should be used very cautiously, carefully. Then another drug, in that again only pharmacokinetic differences are there with various drugs like tindadazole, secnidazole, or nidazole. All these nidazoles are there. You can have a table of this because basic mechanism is same. The differences are mainly pharmacokinetic. So anything we can have. Only what specific changes are there you can note down in a tabular form. Next drug is emetine and dihydroemedine. These are analogues of this emetine. It is a plant alkaloid which is derived from ipecac, or we call it as ipecaguna. It is the synthetic analog of emetine is a dihydroemedine. This having erratic means not confirm. It's in some person it can be very good absorption, in some person it cannot be good absorption. So absorption is we cannot say that this much absorption is there. In some it can be very good, in some it cannot be good. So we call it as erratic. Erratic doesn't mean that irritation. Here erratic means uncertain, abnormal. Okay, it is uncertain. That is called as a erratic. Sometime more, sometime less. It is erratic. It is given preferably subcutaneously, but it could be given by intramuscular use. It should not be given by intravenous use. Plasma half-life is 5 days. The emetin is concentrated in liver, lungs, spleen, kidney, cardiac muscle and intestinal wall, metabolized and excreted slowly via kidneys. So it has got a cumulative effect. Trace amount can be detected in urine after 1 to 2 months after last dose. It should not be used for more than 10 days because it is getting accumulated. It acts on tissue topocytes which are causing irreversible block of protein synthesis in this. So these topocytes will not able to make the protein synthesis. Dehydroemetin is less toxic than emetin. Pain at the site of injection. It can cause abscesses, that is pus-filled फुंसिया फोड़ी जो बोलते हैं हम, GIT, nausea, vomiting, diarrhea. It can cause neuromuscular weakness, and there are serious toxicities like cardiotoxicity, like arrhythmias, hypotension, and heart failure can occur because of this emetin dehydroemetin. It is used in amoebic liver abscesses, intestinal wall infections, and it is used in the severe form of amoebiasis, that is we call it as acute amoebic dysentery. Dehydroemetin is preferable due to comparatively less toxicity for 3 to 5 days. It is contraindicated in heart diseases, kidney diseases, pregnancy and children. It is not used. Then chloroquine, which is it is an anti-malarial drug otherwise. It can be also used as an anti-amoebic drug. It is used in combination with metronidazole and luminal amibase as luminal amicide for amoebic liver diseases. Other luminal amibicides which are working in lumen, these are acts on the luminal parasites. They are used for the treatment of asymptomatic amoebiasis. Example of these are diloxanide furet, idoquinol, and there are some antibiotics like paramomycin, tetracycline and erythromycin. This can be used. First is diloxanide furet. It is the ester of diloxanide and furic acid. It can be given orally. It will split in intestine, and most of the diloxanide is absorbed. It is conjugated to form a glucuronide complex and excreted in urine. Unabsorbed diloxanide, which is around 10%, it is an amoebicidal agent. The mechanism of action of diloxanide is not clear, but it is working against luminal form. It is not active against topocyte in the intestinal wall or extraintestinal tissues. So they are working on the cyst form. Therapeutic uses drug of choice for asymptomatic intestinal infection. For eradication of infection given along with the all form of amoebiasis. Dose is 50 mg 3 times a day for 10 days. Adverse effects are flatulence, nausea, vomiting, abdominal cramps. Otherwise no serious adverse effect. If it is not a cardiovascular disease already been present in the people, then it is that way safe. Contraindications are in pregnancy and children. Then next is paramomycin. It is an aminoglycoside. It is not absorbed, therefore it is used in that way. It is effective against luminal form of amoebia. Mechanism is it has got direct amoebicidal action. It causes leakage by its action on the cell membrane of parasite. It causes indirect killing of bacterial flora, essential for proliferation of pathogenic amoeba. So no bacterial flora, therefore this amoeba will not able to thrive on that. It can be given orally. Not significantly absorbed from GIT. Small amount absorbed is excreted unchanged in urine, and it can accumulate with the renal insufficiency. If the renal insufficiency is there, it will accumulate, and then accordingly doses should be adjusted. Adverse effect, it causes GI distress and it can cause diarrhea. Now paramomycin, already amoebic dysentery can be there, but it will also cause diarrhea. Care has to be taken accordingly. Precautions: severe renal diseases and in patients with GI ulceration it should not be given. Tetracyclines are a very weak direct amoebicidal action. they act indirectly on the bacterial flora. So killing bacterial flora will not allow any food for that protozoas, and accordingly they will starve. So it is used in the severe cases of amoebic dysentery, which is not responding to metronidazole, which is combined with the dihydroimidine. So this is a third agent which may be added. Then very popular drug once upon a time is idoquinol. That is mechanism of action is not known, but it is very effective against organism in GIT only. It is not useful once the bacteria gets inside the intestinal wall or in the liver. Absorption is poor, so 90% will be excreted in feces, 100% enters circulation, and it is excreted as glucuronide in urine. Half-life is around 11 to 14 hours. It is used as a lumen amoebicide. It is for eradication of infection, given along with the tissue amoebicide like metronidazole. Very popular adverse effect which is associated with this is known as optic neuritis. That is peripheral neuropathy, and optic neuritis is there. That is very commonly known as SMON. Okay. This SMON was more common in the Japanese people, and because of that the drug has been banned at many places. Although it was not seen in other places much, but as I told you, in Japanese it was there, this optic neuritis. This was more. Then GIT, it causes nausea, vomiting, diarrhea. It causes enlargement of thyroid gland. It causes agranulocytosis. Since it is going iodine, so it causes iodine sensitivity. It interferes with the thyroid function test because it increases the protein bound serum iodine level, and therefore it decreases the measure in I31I, that is iodine 131, or radioactive iodine, which is used for the diagnosis or treatment in the thyroid diseases. So it will be affecting, it will be interfering with it. Contraindication, it is not used in optic neuropathy. If already been detected previously, it cannot be used in thyroid diseases. It cannot be used in case where there is a sensitivity to iodine. It is not used in severe liver diseases, severe kidney diseases, and it should be discontinued if it produces persistent diarrhea or signs of iodine toxicity like dermatitis, urticaria, pruritus, fever, etc. In that cases it should not be used. So let us categorize this drug. If the clinical syndrome is asymptomatic, that is they are just carriers. Suppose in one family, 2 or 3, there are 4 or 5 people, and 2 have diagnosed with the amoebiasis. So there are every chance that the other may be having asymptomatic, or they are cyst carrier, because cyst is present, and until and unless it is converted into trophocytes, it is not acting. So in that cases, what drug has to be given? So these are the, we can say that is, it is a prophylactic treatment for the carriers. There is no symptom, still we are giving it. The drug which are given, these are idoquinol or paramomycin or diloxonate furoate, because they can act on cyst. Okay, why not metronidazole? Because it is not acting on cyst, it acts only on trophocyte form. Then already diarrhea, dysentery, or that is a symptoms has started, and there may be chance of extra intestinal, example it reaches to liver, and nowadays we call that it reaches to brain. So in that cases the treatment is metronidazole, because it is both luminal as well as systemic. So metronidazole plus idoquinol can be given, or metronidazole plus paramomycin, or metronidazole or diloxonate can be given. Now you can see that metronidazole is working in trophocyte, and these above 3, idoquinol, paramomycin, and this diloxonate, they are particularly working in the cyst format, or they are luminal one, and the metronidazole is luminal as well as systemic. So in that cases this combination should be used. When there is amoebic liver abscesses, then chloroquine is comparatively better than other drugs, and it can be combined with metronidazole, or it can be combined with imidine. Here we are not adding any of the luminal agents like idoquinol, paramomycin, or diloxonate, because here in liver we need the drug which is working for systemic type of infection. And lastly, what are various treatment, asymptomatic intestinal infection, then give luminal agent like dialloxanate furoate 500 milligram 3 times a day for 10 days, or we can give iodoquinol 650 milligram 3 times a day for 21 days, or paramomycin can be given 10 milligram per kg 3 times daily for 7 days. When there is a mild to moderate intestinal infection is there, it is understood by amoebic dysentery. It is very typical. It causes very squeezing type of pain, and we call it in Marathi. Yeah, even in Hindi people say marda, yeah, murda, aisa. So this is giving that particular type of then otherwise can be given iodoquinol or paramomycin 10 milligram per kg 3 times a day for 7 days. When there is a mild to moderate intestinal infection, metronidazole is the best, 750 milligram 3 times a day, or 500 milligram intravenously every 6 hours for 10 days, plus luminal agent, any of this luminal agent like dialloxanide or iodoquinol or paramomycin. Alternatively, what we can do is luminal agents plus tetracycline can give, if somebody cannot tolerate metronidazole, then can give tetracycline or can give erythromycin. If they cannot tolerate metronidazole or all the congeners like tinidazole, ornidazole, secnidazole, anything like that. When there is a severe intestinal infection, then we have to give metronidazole 753 times day for 10 days, same as above, plus luminal agents like above. If we have got any problem, then again we will give same thing like luminal agent plus tetracycline or dihydroimidine or imetine, depending on the case. We will prefer dihydro as far as possible. Then in cases of hepatic abscesses, that when the it has been reached to liver and other extraintestinal diseases, then we will give metronidazole 753 times a day or 500 mg intravenously every 6 hours for 10 days, and luminal agents like dihydroimetine or imetine 1 milligram per kg subcutaneously or intravenously for 8 to 10 days, followed by liver abscesses, followed by chloroquine, which is used only case of liver abscesses. So chloroquine will be there, 500 milligram twice a day for 2 days, then 500 milligram daily. This is why chloroquine even we will see during anti-malaria, but let me tell you, chloroquine in that case, initially it takes long time to make the plasma concentration, because it gets into various tissues, so its volume of distribution is quite high, and because of that it takes time for achieving the concentration, and therefore initially chloroquine has to be given in almost double doses for first 2 days till it acquires, till it reaches to the optimal plasma concentration, and then so here the concept of loading dose. So initial dose, which is high dose, is called as a loading dose, that is 500 milligram twice a daily for 2 days, and then 500 milligram daily for 21 days. It is called as a maintenance dose, and we can add any luminal agent. So this is how the treatment for various amoebic diseases we can have. Then other disease, this is the malaria. I will go for malaria. Similar to amoeba, there is a very good life cycle of malaria also. It is also a protozoa which have a typical lifestyle, typical life cycle, and on that basis we have drugs which are acting at various places of life cycle. And again, there are various varieties of malaria. I'll suggest you to read it before that, what are various causative agents You can make a chart, we can make a table like situation, causative agent, what are the sign symptom, which part is affected more, then what are the typical signs. Example, we call it as a tertian type, means on third day there is a fever is there. Some are quartan type, that is on fourth day there will be fever. So this type of differential features are there of various malaria. The various causative organs are there, microorganisms are there, which are resulting into this kind of malaria. You can go through it so that you will understand what kind of malaria is caused by which drugs, and variety of malarias are there. Second important thing is you can see the global information about it, that how some of the areas have developed resistance for one or other kind of anti-malarial agents, and which anti-malarial agents can be useful in various kind of malarial infestation. So these are how various malaria related information you can have in the beginning. If you read the malarial life cycle, it will be easy, we can go through fast if everybody understands. And then how various drugs are acting at various phases, we shall see about it. What should be the preferable drug in various, we have seen there are various type of organisms, or various types of, we can say, protozoas which are causing this. So these different type of protozoa, how we can classify and how we can relate it. So please go through it. If you have any difficulty, you can ask me, and take care, be safe.